This is a case of hysterectomy in a nulliparous woman who is 41-year-old. She has had a previous vaginal myomectomy for a subserous fibroid about 7 centimeters 15 years back. So as you can see here, I'm doing the bladder dissection. The bladder is densely adherent, and you can see that I'm not able to get the plane here. So I have started central dissection to begin with the myoma screw as the traction. So traction counter traction is the main thing for laparoscopic surgeries, where the energy source can be used optimally if there is good traction, and also where the plane of dissection will be good because of the champagne effect of the carbon dioxide air which enters and creates the plane. So millimeter by millimeter dissection has to be done so that the plane can be identified, and if we are in the right plane, then the bleeding will be very minimal. So here you can identify that the UV fold is opened, but I'm not able to even find the plane either centrally or in the lateral plane. In such situations, it becomes challenging, as in cases of previous cesarean or previous abdominal surgeries involving the lower uterine segment, the adhesion will be in the center and that will be slight high up. So here the adhesion is even in the low down because the dissection has been done through the vaginal route. You can see that there are small bleeders here, which we can coagulate using the shearer itself, giving short bursts of current and making sure that the current is not given for a long period of time. So what the trick is here, to use short bursts of energy source, then give a break, and then again you can give the short burst. So this is a case of multiple fibroids which you can see here, and I'm using the bipolar shearer to do the dissection. I don't use harmonic, though harmonic many people prefer. So now I'm coming to the lateral edge. You can see on the left lateral side again there is lack of plane, so I tried to go above the vessel, but still there is some amount of fibrosis and adhesion even in this plane. So this happens when there is dissection which has been done from the vaginal route. So in this case, the vaginal myomectomy, which was done 15 years back for a 7 centimeter myoma, which was subserous but extending slightly into the myometrium, is what is written in the case paper. Now again she has developed multiple fibroids. So now you can see centrally also I'm not able to reach till the vagina, and on the right side also there is still dense adhesion which you can see. Always try and hold the full bladder and not just a UV fold when we want to dissect it. So in the lateral, so this is the above the vessel that I am doing the dissection. If we go slightly deep down, we will enter the myometrium. So once we find a plane, even then here in this case it is slightly difficult to just go and cut it because of the adhesion which has been formed like a band. So always try and orient yourself to the anatomy and then start dissecting. So having a panoramic view and having the right orientation with good camera assistance is extremely important in such cases. Otherwise it is very time consuming, and also the complication rates will be more in such cases. I have not used the vaginal tube here or any manipulator from the vaginal end. And sometimes I find this is much more easier, as the things are more anatomical, and identifying the plane is slightly difficult than when we put the vaginal tube, but with experience this is much better compared to the vaginal tube. So here I am lifting the bladder entirely from from its attachment. But even then I'm not able to find that plane with just the dissection without the energy source. So I have to use energy source which wouldn't have been required if there was no adhesion in this case. So you can see again there is a lot of fibrosis here, and there is no plane between the bladder and the cervix that I can identify and cut. So I have to just take that leap of faith and start cutting, hoping not to injure the bladder, and even if it injures, I'm willing to suture the bladder. So this patient has opted for hysterectomy and not myomectomy, though she is nulliparous, because there are multiple fibroids and she is not very keen on fertility. And recurrence of fibroid after once myomectomy is about say 15%, and if it recurs after 2 times undergoing myomectomy, then the recurrence is almost close to 40 to 50%. So recurrent myomas is again a challenging condition where repeated myomectomies are not advisable, and we'll have to counsel the patient regarding the same. So here you can see that there is a dense band of adhesion, which I'll have to just cut it. So you can see here the camera is coming close, and then I'm cutting it. You can see I have opened something. I thought it was bladder which I have opened, but I will continue the dissection as I have decided that I will check it a little later. Now the urine is clear, and also there is no air in the uro bag. I have already put the Foley's catheter for her, and we have to close the cap of the full urosac bag. And if there is air in the urosac bag, then that means the pneumoperitoneum air, that is the carbon dioxide, is getting filled at the urosac bag. So since I'm not sure about the plane, I thought I will start the dissection from the right side. So this is the round ligament. Always cut the round ligament as laterally as possible in such cases. I'm using the shearer itself, alternating between the coagulation mode and cutting mode, which are there in the foot pedal. So the fat which you can see here doesn't belong to anybody, so you can just keep cutting in that fat layer, and you will reach the right plane. So when it comes to this band, the one which I'm cutting now, so this is the band which is formed along with the UV fold because of the previous surgery. So this kind of the band formation and adhesions is a very personalized case, as in it depends on individual cases as to how the adhesions will form, and there are various factors, and the most important factor is the patient factor. If the patient is prone to develop adhesions, then she will be prone to develop. There are various ways which we can minimize the adhesion formations, like using Vicryl as a suture material and not catgut, using the adhesion prevention methods like intraseed and all. But I think the most important factor is the patient's factor, and how the healing happens in that particular patient is what will determine the amount of adhesion. So you can see the myoma screw which is coming in from the right lateral port here, and I had put it at the fundus. So now I have changed the myoma screw because I want more traction. There is another band of adhesion here between the fallopian tube and the fundus of the uterus. So I'll start with the right adnexa. After the round ligament, I'm doing this. So these sequence of dissection can change depending on what you're comfortable with. I'm doing the dissection from the left ipsilateral ports only. My upper left port has the shearer, and the left lower port has the non-tooth grasper. We can use tooth grasper also for this purpose, but I prefer to use the non-tooth grasper. So when we come into this broad ligament area below the adnexa, this is when we have to be careful that we have to take only the posterior leaf of the broad ligament to cut this peritoneum. This is to mainly lateralize the ureter. Many a times when there is a fibroid like this, and when the uterus is quite enlarged, as in this case where the uterus size is almost about 18 centimeters, that time the shearer may not be easily reachable, and the direction of the shearer will not be as we want, because the fibroids will be obstructing our movement of the shearer. So try and lateralize the ureter as much as possible. If it is not possible from the left port, then better to use the right port, so that we can make sure that there is no ureteric injury in these cases. So uterines also will be slightly enlarged because of increased vascularity. As the uterus is large in size, it is distorted. Skeletonizing the uterines is one of the important steps in these cases. I have not done the uterine coagulation at origin in this case, as I thought I would be able to manage without doing the uterine artery at ligation. So now I'm doing the left uterines. I'm using the Bissinger bipolar here, though directly we can use the shearer if we are confident. If we are using the shearer, then we have to use the ligation mode button in the foot pedal. If we are using directly the shearer, which can coagulate up to 5 millimeter vessels of the uterines. But I want to be more cautious, as if it starts bleeding here, the vision will get blurred and it will be bloody. Also, the planes will get altered once there is fluid where the gas cannot enter in between the planes. So after using the bipolar, now I am using the shearer to cut it. So I cut it close to the medial end of the uterus. So here I have already lateralized the ureter by cutting the posterior leaf of broad ligament, which you can see. There is a fibroid right at the place where the uterines are there. And in these cases, it is very important to cut close to the uterus. As you can see, when I'm cutting close to the uterus, that is the cervix, you can feel it, that the firmness you can feel when you actually use the shearer to cut it. And this is more of a tactile feel that you can get to know after experience. So you go posteriorly and start cutting the whole stump. So this is very similar to what we do in the open hysterectomy. So like in open hysterectomy, here also you have to coagulate at 3 points and then cut in between. If you cut high up, that is too medially, then there will be black flow. If you cut too laterally, then if at all, if there is any bleeding, then it will be difficult to control, as the ureters will be close by. Here posteriorly, once you cut it, so now you are cutting exactly right in between the uterosacrals is what I am cutting now. Then take it the same way to the right uterosacrals. So posteriorly, if we cut the uterosacrals, then the uterus becomes more mobile, as uterosacrals are one of the primary supports for the uterus. This kind of mobilizes the uterus quite a bit. So the sequence of the dissection and cutting can depend on what you are comfortable with, and this comes with doing many cases, and it really doesn't matter whether you cut anteriorly, posteriorly, how you open the vault. All that doesn't depend on the sequence that you do, as long as you take into consideration the right principles. So here is where it had slightly opened, but I'm still continuing with my dissection without bothering about checking the opening, whether it was the bladder or the vagina. So the white thing that you can see here is the cervix, and this cervix we have to keep cutting until we reach the vagina. So during this time, the vaginal vault can open, and we'll have to close the vaginal end with either the gauze with a glove in it, or with the menstrual cup to prevent the air leak. So now you can see that I have opened the vagina here, and then I extend this vaginal vault opening. So once we get the vaginal vault opening, then it becomes slightly easier to go and kind of do the rest of the surgery. So the advantage of laparoscopy is that you can see that the vaginal vault clearly, and we can cut close to the vaginal vault here, where that is the cervico-vaginal junction, and this helps in maintaining a good vaginal length. So here the trick is to again catch hold of the cervix and lift it. Here I have still not yet done the right uterine dissection, so I am still continuing with the left side. So this again depends on case to case basis, and how we want to go ahead, and to minimize the time, that is without changing the ports too many times, the instruments coming out and going in too many times. So this is one of the ways where you can completely finish from one side where the vault is open, so you know where to actually cut where the vault is, and again go millimeter by millimeter, keeping the field clean and not letting the too much of bleeding happen is one of the tricks to achieve a good surgery and a quick surgery. Otherwise you will have to keep suctioning, or you will have to put a gauze to mop it and keep the field clear. So here I have reached almost to the end of the vault on the right side, and I continue. So once you notice a little bit of bleeding is when you will have to stop doing this, because that will be the ascending branch of the uterine artery, that is the ascending branch which comes through the from the cervix. It ascends up into the uterine cavity. So that you can see here that I'm slightly close to the vasculature now. So yeah, this is when we have to stop doing it, because the uterines have to be coagulated on the right side to prevent further bleeding. Otherwise once it starts bleeding, it will be difficult to control, and this is the area where again the chances of ureteric injuries also will be high. So I am untwisting, I'm taking out the myoma screw, and I will be putting it from the left port. So till now the myoma screw was coming in from the right port. Now I will put it from the left port, because I want the right port free to coagulate and manage the right uterine till the vaginal vault. So again, once the one side of the uterines are coagulated, the vasculature or the blood supply to the uterus comes down drastically, and here you can see that the uterus is becoming very mobile, because it's almost free of all its attachment except on the right side. So try and manipulate and keep it in the anatomical position, so that we know where we are actually going and coagulating and cutting. Skeletonization of the uterines is very important in big uterus, because The vasculature has to be completely coagulated and cut. If we take a big chunk of tissue like how we do it in open surgeries, then the hemostasis may not be complete, and we may keep buzzing it again and again to achieve hemostasis, but the energy delivery will be quite high in such cases. So here you can see that coming in from the right side of the right port helps in preventing ureteric injury, because it is just like how it is in open surgeries, where the shearer and also the bipolar basinger is almost coming perpendicular to the uterines. And once we cut the uterines, you will now see that there is a stump which is getting formed. So forming this stump is very important, and having a good stump is important, because if there is any bleeding, then we can go and coagulate at the lateral area without actually worrying about the ureter. So once we cut it again, cutting it posteriorly will release the uterus quite nicely. And here again, traction is very important, because without good traction, the cutting will not be very good, and we keep using the energy source unnecessarily to cut it. So as you can see here, I'm reaching the vault here. Here it becomes easy, because already I have cut the vault almost throughout from the left side till the right side. So just pull on the myoma screw towards the cranial end of the patient, and you will be able to achieve the good traction. So changing the tip of the shearer or even the Bissinger bipolar helps in giving the right direction energy delivery, because that is also equally important, as the vessel has to be caught in between the blades of the tip of the shearer. So otherwise only one end of the vessel will be coagulated, and it will still be open. So here almost we have reached it. So here the opening which was there, which I had cut, that was not the bladder opening, that was the vaginal opening, which we checked using the methylene blue, and the bladder was intact. So here I will be taking superficial sutures to close the vault, because the bladder is very close to the vault, and I am not able to get the complete dissection of the bladder. Thank you very much for watching. This is the salpingectomy, which I will finish. I have left behind the ovaries in this.